Greetings everyone, and welcome to a very special Clinical Omics webinar. Our presentation today is entitled Addressing Challenges of NGS Data Interpretation for Hematological Malignancies. I'm Jeff Bogaliskas. I'm Technical Editor for Clinical Omics, as well as Jen, and I'll be helping to moderate today's webinar. Next-generation sequencing is quickly becoming an indispensable tool to aid clinicians in the diagnosis of various diseases, and in particular cancer. As new molecular diagnostics continue to rapidly enter the clinical arena, investigators are facing the challenges of transitioning this powerful genomic tool from a benchtop gene discovery method to a routine precision medicine diagnostic. Applying next-generation sequencing to hematological malignancies has become of particular interest as of late, and our panel is here to discuss how they and their respective institutions utilize this powerful tool to aid patient prognosis and care. So before we get started with our panel discussion, I want to encourage the audience to submit questions for our Q&A session at the end of the talks. We'll try to get to as many questions as we can, so simply type your question in the Q&A box on the left-hand side of your screen and hit submit. All right, let's meet our panel and get our discussion underway. Greetings everyone, and welcome to a very special Clinical Omics webinar. Our presentation today is entitled Addressing Challenges of NGS Data Interpretation for Hematological Malignancies.
Harvard and did my postdoctoral work at MIT, and before moving to N of 1 9 years ago. At N of 1, we are a clinical interpretation company. We focus on interpretation of molecular profiling data for somatic tumors. And we partner with molecular diagnostic labs and clinical laboratories to bring information from the literature and help doctors to understand the complexities involved in the molecular profiles of tumors. And my role at N of 1 has been as a scientific director. I've been with the company for almost 9 years, and we've built up a scientific team to curate this literature, and I've led the development of that database. We're joined today by 3 experts in the hematological oncology field. Dr. Andrew Lane, who is from the Dana-Farber Cancer Institute, Dr. Kristen Champion, who is from MedFusion, and Dr. Gregory Riedlinger from Rutgers. And I'd like to hand it over to our panelists to introduce themselves. Dr. Champion.
Hi everyone, it's great to be with you all today. My name is Kristen Champion. I'm a board-certified clinical molecular geneticist by training, so I'm going to offer you all the laboratorian perspective during our discussion today. I've been a laboratory director for about 7 years now, and I'm currently lab director of the molecular genetics section at MedFusion, LLC. And MedFusion is a mid-sized commercial reference laboratory that's headquartered in the Dallas-Fort Worth area. We serve the U.S. Oncology Network, which is the largest network of community-based oncologists in the U.S., as well as several large regional hospital systems throughout the state of Texas. My lab is a very active and busy molecular lab. We're primarily focused on oncology-based testing. We perform a broad range of testing, which includes next-generation sequencing panels for both solid tumor as well as hematologic malignancies. We've been offering our NGS testing for solid tumors for nearly 3 years now, and we've recently introduced our heme panel NGS testing, and we've been live with that for about 7 months.
Great. Thank you, Kristen. And Dr. Riedlinger?
Hi, I'm Greg Riedlinger. Thank you for having me here today. I'm a board-certified anatomic pathologist, and I've also done fellowships in pathology informatics at Mass General and molecular genetic pathology at the University of Pittsburgh. Rutgers Cancer Institute recruited me in, I guess, August of 2015, and I've been involved in their precision medicine initiative where we sequence a large number of rare and refractory tumors and present weekly at a genomic tumor board. And my major role at Rutgers is as a molecular pathologist. So I sign out a lot of conventional molecular pathology tests, but have also been involved in bringing on a 50-gene solid tumor panel, a 49-gene myeloid panel, and then a 15-gene solid tumor panel most recently.
Thank you very much. And Dr. Lane.
Hi, great to be here. My name is Andy Lane. I'm a physician scientist at Dana-Farber Cancer Institute in Boston and assistant professor at Harvard Medical School. I see patients in the leukemia clinic, and I have a basic science lab where we study leukemia genetics, trying to find novel therapeutic targets. We have a lot of experience in the last few years here at Dana-Farber with various sequencing panels that we have designed in-house and some that we've used from outside, and have some perspective on how we've been trying to integrate those sequencing panel data into our clinical practice.
Great. Thank you all so much for being here today. I wanted to start with how you've seen of testing in hematologic malignancies evolving over the last 5 to 10 years. And Andy, I was going to turn to you first to ask for your perspective.
Sure. There's been a major evolution. I think, we think in the heme malignancy space that we are at the forefront of, gene sequencing in association with disease. It really all started with BCR-ABL and CML. And we've had a few examples like that where what we did in the past was you had patients that presented with a certain clinical picture that made you suspicious that they might have a particular molecular abnormality. You would send a single gene test for that. That started with BCR-ABL and then evolved to things like the JAK2 mutation in myeloproliferative neoplasms, to now multiple genes that are known to be recurrently mutated in heme malignancies, such that there are many multi-gene panels that I've seen both here at Dana-Farber and in patients that are referred to us from the community that seem to be in fairly routine use. Most heme malignancy patients, it seems, will have some kind of multi-gene panel sequencing done at some point in their care. And so those multi-gene panels now include many of those single genes that we knew previously had either therapeutic or maybe prognostic significance, but now have added numerous others, and we're having to integrate all of that data together when we see a new patient.
And I think this is Gregory Riedlinger. I think from the lab side, obviously we're seeing some of the same things, that it's going from a lot of single gene tests such as BCR-ABL and JAK2 to an evolution towards these panels that take advantage of some of the properties of next generation sequencing that are advantageous compared to the single gene tests, including having higher sensitivity and quantitation of approximate quantitation of mutation frequencies, and interrogating multiple targets and then even multiple samples at the same time. But from the lab perspective, that comes with additional challenges in the analysis of the data, filtering of the data, variant interpretation, reporting, and storage.
Yeah, hi, this is Kristen. So I would echo all of that was just said. In my lab for the heme malignancies, we've been offering fish panels and a small menu of single gene molecular assays such as JAK2 and NPN1 for AML, et cetera, for quite a while, but no sequencing-based panels until recently. And I think sequencing-based panels for heme-related cancers, they have lagged a bit behind in the solid tumor world, where we've been performing sequencing panels for quite a while now. And then really starting a couple years ago was when we began getting requests from our oncologists wanting to know our plans for gene panels for heme-related disorders. And I think there's a few reasons why we started getting the increased interest. As Andy mentioned, we're seeing more and more genes that are being discovered to be clinically relevant. For example, in the MPN-related disorders, we only had JAK2 for a while, and then we got MPL, then we got CALR, then AXL1, and now others. And so gene panels started making more and more sense, and the single gene assays started to take a back seat. Again, another reason is at the same time we're seeing more genetic testing that's now being specified in the professional guidelines. For example, the CAPN, American Society of Hematology, just published as an early online release document guidelines on the initial workup of acute leukemias, and that document specifies the use of molecular genetic testing as both a recommendation and a strong recommendation. So I think our oncologists and pathologists are becoming more inclined, more comfortable with ordering genetic testing for the heme-related disorders. Also, we're seeing more labs offering it, more competition, so that's also raising the awareness.
Thank you very much. That sort of leads right into my next question, which is about panel design. How do you panel design? What sorts of panels are you using in your laboratory? Are you using small panels, large panels, pan-heme panels, focus panels? And I'll point back to Kristen to start with that answer.
Sure, I'll start with that. So here at MedFusion, we've been working very closely with our in-house team of hematopathologists as well as the treating oncologists that we serve to really determine what our roadmap is for developing gene panels in heme. We wanted to understand how they intended to utilize these panels, what disease states were of the most interest, what genes were important. That's always a lively discussion. What the testing algorithm would look like, so how the sequencing panels would fit in with the FISH panels that we already offered, what was the expected turnaround time, etc. So we ended up strongly favoring smaller disease-focused panels. That's the feedback and the direction that we've received from our oncologists and pathologists. They want just the right information. They don't want too much information that they don't know what to do with. So our strategy here at MedFusion has been to offer smaller, more focused disease-specific panels. For instance, we have a panel for CLL, for MPNs, for AML, etc. And we're about to launch an MDS panel. So all these panels utilize the same master gene panel, which includes about 40 genes. And we report only on a subset of those genes that's relevant to the disease that's requested. So this allows us to modify our panels relatively easily to subtract or add genes that are already on our master panel as they become relevant, maybe in another disease state. We've already made a minor update to our MPN panel to include 5 additional genes that were specified in the most recent NCCN guidelines. So we were able to react quickly to changes in the field, to update our panel and provide our oncologists with the most clinically relevant panels.
So this is Greg again. So at Rutgers, as part of the Precision Medicine Initiative, I think similar to what was said previously, we sat down with our hematopathologist and our treating oncologist, and the decision was made for molecular next generation sequencing to go with a 49 gene targeted panel that was mostly going to be used for myeloid diseases. And this panel, we're only detecting single nucleotide variants and insertion deletions. And I think at our institution, and I guess with some of the restraints with reimbursements and things like that, that was the decision that was made. I think a lot of times at academic institutions, there's always the desire for more information and bigger panels that are able to detect additional abnormalities. But I think working within the constraints of our department, this is what we felt would be most effective.
Yeah, this is Andy. So at Dana-Farber, what we use is a 95 gene panel we call the Rapid Heme Panel, and it was really designed within our group because of wanting that rapidity. So there were some solid tumor really biased sequencing panels that had been in place already, but they had a 4 to 6 to 8 week turnaround time. And for our heme malignancy patients, some of them need an answer sooner than that, either because it would be important for a clinical trial decision or because they're sick and you need a therapy right away. And so this panel is a bit biased toward myeloid diseases, although in theory it also covers some lymphoid diseases. And so that's sort of what we use. And what it has actually evolved over time, even using the same panel. We didn't used to have copy number changes reported on this, but now with 3 years of data, our molecular pathologists are able to sort of normalize each sample back to the bulk of data that's come in the years before, and so they can make some copy number inferences that they weren't able to do before. So even the same panel has actually evolved in the data that's able to give us over time.
This is Kristen again. That reminded me, I just wanted to mention one other important aspect that we've implemented in our panels. So we integrate the reporting of our FISH panels into our testing algorithm. So the client will order an entire profile, which includes the FISH panel as well as the sequencing panel. And so we interpret both of those results together, which we feel adds significant clinical value. So for instance, for example, we had a recent CLL case where we had a trisomy 12 detected on the FISH panel and a Notch1 mutation on the sequencing panel. And so we interpreted a combination of those findings, which changed the prognosis to a worse prognosis for the patient. And this is something that we worked closely with N of 1's interpretation service to be able to help us identify when we have what we call a significant interaction between findings that we feel is clinically significant to report.
Thanks very much for adding that, Kristen. The next question I wanted to ask the panel, what role do you see for NGS sequencing in heme disorder diagnosis? And when we're talking about diagnosis, differential diagnosis between two different disorders or a sort of broader diagnostic question? And I'll look at Andy first for how you use it in your practice.
Yeah, it's a great question, and this is in evolution as well. So I think there's a couple things. One is if there are mutations that are very much associated with a particular disease, where finding that mutation might help you distinguish between a few possibilities. Some of those are things like a JAK2 mutation in a myeloproliferative neoplasm can help bucket the patient into a certain category. Another might be something a little more esoteric, but Waldenstrom's macroglobulinemia is a B-cell lymphoma that has almost 100% of the patients have a mutation in the gene called MYD88. And so if you have a patient who you think might have Waldenstrom's, but then they don't have a MYD88 mutation, you might think twice about the diagnosis. The other thing that's coming up much more, exploding, I would say, in the last year or so is sequencing in a patient that you're not even sure has a heme disorder at all. So patients who have maybe an abnormality in their complete blood counts in their peripheral blood, sequencing panels are being sent. This can be often by our benign hematology clinic colleagues. And we didn't know what to do with that data until recently. There have been at least a few papers now published of a series of patients where finding a mutation in a single mutation in one gene doesn't necessarily tell you the person has a disorder because of the phenomenon of clonal hematopoiesis that happens with age and some other things we could talk about more later if we want to. But there are some data now to say that, for example, if you have two genes mutated that you detect in a patient, or you find a high variant allele fraction of a particular mutation, those actually are associated with the likelihood of finding something if you were to do a bone marrow biopsy in those patients. So that's the other place where gene panels are now, I think, going to become more in use, which is sort of diagnosis when there's not even a clear malignancy present.
So this is Greg again. At Rutgers, we're not quite at that point yet. We're using these panels where there's not a clear diagnosis. We're typically using it where the clinicians at least have some idea what's going on, that there may be a myeloproliferative neoplasm, and they're looking to see if it has JAK2 or thrombopoietin receptor, or CALR, and then the other major use really is prognostic significance. And I think Kristen talked about this a little bit, that some of the AML with specific cytogenetic abnormalities are associated with specific prognoses depending on what mutations we find on these panels. And our clinicians are also looking at the presence of some of these low-level mutations in certain genes like DNMT3A and TET2 after induction therapy in intermediate risk AML, I think mainly based on a paper that came out in JMA last year to help further I guess, give further prognostic information to these patients.
Hi, this is Kristen. So our experience has been more similar to Greg's, and since we offer disease-specific panels, strictly speaking, the intended use of our heme panels is that they're intended for patients that have a clinical diagnosis of CLL or AML or what have you. That's really the only way that we were sure we could provide a clear and meaningful interpretation of the results is to know what disease context to put it in. As a reference lab, we very often don't get very much clinical information about the patients that we're sequencing. That said, in real life, we're definitely seeing our panels being ordered on patients that don't have a clear-cut diagnosis. And we know that because sometimes we're even seeing clinicians order multiple different of our disease-specific panels in order to cover all of the genes that are relevant in the possible differential diagnoses. So we're kind of working to address that kind of use of our panels. We're working towards offering disease overlap sort of panels for MPN or MDS overlap syndromes, or for patients with progression to secondary AML. So our experience is kind of evolving. We initially just envisioned a strictly defined intended use based on diagnosis, but in real life, we're seeing the lines being blurred, definitely.
Thank you very much. And as a follow-up to that, how do you see the role of NGS sequencing for heme disorders in terms of prognosis? How does NGS help you with prognosis? And also, what do you feel that is more important in terms of an outcome? And is it prognosis or is it predictive biomarkers that you're looking at when you're looking at heme sequencing? Greg, do you want to start with that one?
Sure. I mean, I think we're still with these panels. We're still using some of the ways that they were used with the single gene assays in terms of looking at NPM1 and FLT3 in cytogenetically normal AMLs and giving prognostic information that way. And then it seems like there's additional data coming out with some of the cytogenetically abnormal AMLs that certain mutations can kind of give you additional prognostic information. What we're really only just beginning to see, I think, is potential treatment decisions. Much more in the solid tumor world with some key alterations. There's obviously FDA-approved therapies, but in the myeloid world, just recently. There's the approval of the FDA-approved FLT3 targeted drug for FLT3 mutated AML.
This is Kristen. I would agree. I would say prognosis is a very important use for the heme panels, and we're even seeing new therapeutic options that are coming out along the way. But there's many examples of genetic markers or combination of genetic markers that have a clear-cut prognostic implication for our patients. For example, we now understand that the combined CALR ASXL1 status was very important in the prognosis for our MPN patients. Their survival is longest for patients who are CALR positive, ASXL1 negative, compared to patients that have other combinations of those two genes. However, we still come across many findings where there's just not sufficient information to be able to provide the clinician with a clear-cut prognostic or therapeutic role of the findings. There may be some evidence, but it might be weak evidence that's powered by small-scale studies, or there may even be conflicting evidence in the literature. So it's difficult to know what to do with that information in many cases. And when we do have to issue a report to that effect, I wonder, what is the clinician going to do with this information? Are they going to consider it in the treatment plan of the patient, or do they largely just ignore it?
Yes, Andy, I just want to emphasize why this is really important. The prognostic information is critical, especially in heme malignancies, because one of our biggest decisions in the clinic is whether we're going to send a patient for a stem cell transplant or not. And why we weigh that decisions so carefully is that there's a significant morbidity and mortality associated with undergoing a stem cell transplant. But if your patient has a very, very poor prognosis with their disease, the chances of them having long-term good outcomes may be much better with taking the risk of the transplant, whereas you wouldn't want to subject a patient with a better risk disease to a transplant if the transplant would then result in more potential morbidity than they would have had with their disease. And so for a long time, we've been trying to take whatever information we can and help us make that decision. In the past, it was age and white blood cell count and number of blasts and then chromosomes, and now we're integrating gene mutations into that. And so some things are clear or clearer, like FLT3 ITD mutations or TKD mutations in a patient with normal karyotype AML. We think we send them for a transplant. But there's a lot of patients who don't have that combination, and so what we have to do is analyze large data sets of patients where we have outcome data and sequencing data, and it's starting to come. And so what many of the guidelines, like the NCCN guidelines and others, now are starting to actually list mutation patterns or combinations of mutations with karyotype, for example, that might help you make decisions in your MDS or AML patient about who might be recommended for a transplant. So the prognostic side of this is really important.
Great. So I just wanted to take a moment to pause and remind our audience, please feel free to submit questions to our panelists following the instructions that you see on your screen. And then moving on to our next question. So sequencing being going on, as we mentioned, or as all of you have mentioned earlier, was introduced a bit earlier for solid tumors than it has been for heme malignancies. And I was wondering if you could speak to some of the differences that you see in sequencing in the technical aspects and eventually in the interpretation aspects for solid tumors versus heme malignancies. So, Kristen, maybe you could take a stab first at what are some of the differences that you've observed in terms of sequencing?
Sure. I'd be glad to take that one. So sequencing in heme cancers differs quite a bit from the experience with solid tumors in several different significant ways. One way is that a sample collection is much easier. It's typically a tube of whole blood or bone marrow that can be drawn at the ordering facility and sent to the lab, as opposed to having to locate and retrieve an archived tissue specimen that's housed in another facility. With heme cancer sequencing, we generally don't have the specimen quantity and quality issues that we deal with all the time in the solid tumor realm. We rarely have scant specimens, and the quality of the extracted DNA is very good compared to that which we get from formalin-fixed paraffin-embedded specimens that we typically use for solid tumor sequencing. So because the specimen quality and quantity is very good, we have very, very few test failures that are in very few gene regions that don't reach our minimum sequencing depth requirements. In fact, we rarely see any amplicon drop out at all on our heme panels. Occasionally, we will have a specimen that we don't have sufficient quantity for. It's typically a case where NGS testing has been added on after the specimen's undergone a full workup of flow and immunophenotyping, FISH, et cetera, and there's just not sufficient volume of the bone marrow left for NGS studies. But often, in those cases, we're able to use an alternative specimen, such as the paraffin-embedded bone marrow clot or the peripheral blood specimen. And then another aspect is, which is similar to solid tumors, there are certain genes that give us some interpretive and technical challenges, SEBPA being one of those genes that's very difficult to sequence, that has some interpretive challenges with having to see the biallelic mutations in the classic pattern. FLT3 ITD mutations have some challenges, some technical challenges. So we've had to address those along the way, but that's not really unique to the heme cancers. We see that all the time in other areas of testing.
Yeah, so this is Greg again. I would just echo, our experience at Rutgers, I think, has been similar to, what Kristen is saying, that, generally these, we're getting bone marrow aspirates and blood, and there tends to be, more than sufficient tumor cells for sequencing. In terms of the differences, obviously if it's a hypocellular specimen, that's potentially when we're having failure, or you could have I guess a false negative. Whereas with the solid tumors, the pathologist is always QAing to make sure that there's sufficient tumor for the assay. Whereas I guess generally we've also done a bone marrow where a hematopathologist has actually looked at the bone marrow and said that it's sufficient, but they're not really looking at the aspirate directly. Some of the things that we're starting to see in solid tumors that Andy touched on, we are picking up evidence of low-level mutations in genes that are implicated in clonal hematopoiesis, and we're starting to see evidence when we review some of these pathologic slides that there are, in fact, increased numbers of lymphocytes when we go back and do a QA, of these slides. And obviously we have seen, some of the genes, on our 49 gene panel. I think they were a little bit, maybe more GC rich, where we were having some low coverage, but we tweaked a couple things in the lab to get them with better coverage, where we're typically getting greater than 500x. And then we had to introduce a separate bioinformatics platform, which I guess a number of laboratories have done, in order to pick up the FLT3 internal tandem duplication.
And as Andy, I just want to add one thing that's technical, and maybe the two of you could comment, that we've run into, is that in solid tumors, your specimen for sequencing is either a fresh biopsy or a biopsy that's gone formalin fixed in paraffin, FFPE. And on the heme malignancy side, it's great if you can get fresh blood or a fresh bone marrow aspirate. But our formalin fixed tissue from a bone marrow biopsy gets decalcified first to allow the pathology lab to be able to section it. And what we've seen is that certain sequencing tests do not perform very well on a piece of bone marrow that has been decalcified and then formalin fixed. And so it does mean that sometimes you can't just go back into your archival tissue and pull that bone marrow and sequence it.
Yeah, so we've experienced that as well. Specimens that are decalcified generally don't perform well on sequencing or FISH-based assays. We have seen a difference with short decals. They seem to work better. We've had better success with sequencing on those, but certainly decalcification is a real problem for PCR-based assays.
Yeah, and our lab, we won't accept the decalcified specimens. We kind of experimented with a less harsh, decal solution, but we're still not at the point where, we're using that.
Great, and then I was wondering if you could also comment on the interpretation challenges of solid tumor heme malignancies. Andy, you could start with that one.
Well, yeah, I think this gets something we've touched on a little bit here, is this phenomenon of clonal hematopoiesis. So to take it to the solid tumor side, when you biopsy a solid tumor, it's usually there's a tumor there. There's something that you can see clinically, or there's something radiographically that you're going after. And the pathologist can verify that under the microscope there's some unusual abnormal cells. Oftentimes, when the clinical presenting finding might be abnormal blood counts, and then you send blood for sequencing, it doesn't mean there's a malignancy. There's many other things that could cause abnormal blood counts, and so we thought it would be simple that if you find a mutation, well, it means the person has a malignancy, but it's actually not that simple. So this phenomenon of clonal hematopoiesis was discovered a few years ago, and it turns out that as we age, our hematopoiesis becomes more and more oligoclonal, meaning that instead of hundreds of clones contributing to hematopoiesis, it might be only a few. And those few clones often carry somatic mutations in genes that are associated with heme malignancies like MDS or other myeloid disorders, but the person actually doesn't have MDS or a myeloid disorder if you were to look at that time point. So the implication for that for sequencing is that when you find one of these mutations, the common genes are DNMT3A, TET2, ASXL1, there's a few more, it doesn't necessarily mean that there's a malignancy. It also means that if you had a malignancy that had multiple mutations, as Greg mentioned, and then you receive treatment, and then you find one of these mutations hanging around, it doesn't necessarily mean that that's the malignant clone hanging around. It could be one of these pre-malignant clonal hematopoiesis clones. And on the research side, we're trying to figure out exactly what that means and whether we should treat those patients any differently. But it does complicate things a bit. One thing that we use to help us with that is the variant allele fraction that can sometimes help you sort out which mutations are in which clones, which are co-occurring, but it's not always a slam dunk just by looking at that.
Hi, this is Kristen. So in terms of identifying the small clones at low variant allele frequency, we've somewhat guarded ourselves against that as we filter out variants that are below 5% variant allele frequency. So we're not seeing the really, really small clones. An exception to that is JAK2, the V617F. We do detect lower than 5% for that particular mutation in accordance with the guidelines that have been issued. But in terms of interpretation for heme panels, I think it's more of a challenge than solid tumors in some respects. We follow the same general variant interpretation framework for solid tumors as well as heme, which is a modified version of the FACMG variant interpretation guidelines that we've tailored towards thematic variant interpretation. But there's a few unique interpretation challenges to heme. I would say in general we have just more variants that are detected that we have to interpret. So there's more work to do, more variants that are detected per patient on our heme panels compared to solid tumor. And then overall, I feel that there's just a less body of evidence at the gene level and certainly at the variant level compared to the solid tumor, where the genes and the variants that we're targeting in the solid tumor panels are for the most part fairly well characterized in terms of their clinical relevance and their predictive value. And for the heme genes, the mutational spectrum of the genes is very broad. So instead of a few well-described hotspots, there's mutations scattered throughout the gene, with each mutation individually having a relatively low prevalence. So there's just not a whole lot of studies in the literature about a particular variant. So in effect, we end up with more novel variants, more variants that we end up classifying as uncertain. And that's one aspect that we value our partnership with N of 1 to help us comb the literature and the variant databases to see is there anything at all reported about a particular variant that we can say, or is it a novel variant, is it uncertain significance? And then I mentioned earlier about with the heme NGS sequencing, we have to consider more of the combination of the gene findings that are clinically significant, which is, again, it's very important for us to recognize and be able to report when there's combinatorial effects of the gene findings. And then another challenge is integrating and reconciling our interpretive criteria with the published NCCN guidelines that often mention which genes are relevant and which specifically which types of variants are relevant. And sometimes we find a novel variant, it's mentioned in the guidelines, but there's no evidence, and so we kind of debate what is the significance of that particular variant. So I think in those ways that we have some unique challenges with heme sequencing.
Yeah, so I think I'm just going to echo kind of a lot of what Kristen and Eric said. Obviously with the heme malignancies, one difference between the interpretation with solid tumors is that oftentimes the prognostic significance of the molecular alterations we find are dependent on the cytogenetic results, and that's not something we're doing in solid tumors. And then as Kristen said, the combinatorial mutations can have different prognosis. So if you have a NPM1 mutation by itself, and a cytogenetically normal, it's good prognosis. But if you also have a FLT3 ITD, it's going to be a poor prognosis. And then in terms of the clonal hematopoiesis, we've really only been looking at it so far in the solid tumor world. It's something that we picked up and realized that these mutation patterns with the allele frequencies, they just weren't fitting with what we were seeing or what we were expecting the levels to be in the solid tumor, and it's something that we're aware of there, that these likely aren't driver mutations, and that they're probably associated with the clonal hematopoiesis, but it's not something that we've actually been actively investigating with the heme malignancies, other than trying to make the clinicians aware sometimes if the mutations are at lower levels that they might not have the same significance.
So Zandy, I just want to, one thing about that, though, it's amazing how it all connects together. There were several presentations at the American Society of Hematology meeting this year that in solid tumor patients who have clonal hematopoiesis, they have poorer outcomes after their therapy. And it's for many reasons, including that they then develop secondary myeloid malignancies or other things. And so you never know where these heme gene interpretations are going to pop up as important, even in the patients with solid tumors.
That's really interesting. And I had one other question with respect to solid tumors in terms of prognostic information. As you mentioned earlier, Andy, the prognostic information is very important in heme diseases. Do you find that there's a higher level of evidence available for this prognostic information in heme than in solid tumors?
Well, I don't know about level for level evidence, but there's as good as we have for prognostic relevance for several of these mutations. But I think Greg hit it on the head. What's challenging, if you're just looking at the mutation panel, even combining multiple mutations present or absent together, most of the prognostic scoring systems also include other clinical factors that may not be with you when you're interpreting the report, which include the karyotype, the age of the patient, other blood counts, the number of blasts in the bone marrow. And so it's really sort of as a picture putting it all together where the prognostic information comes in. But it's definitely helpful. And then there's some overlap, right? And so partly by doing panels on patients, we've made observations that have come into clinical practice quite rapidly. For example, P53 mutations, everyone has found that they're a poor prognostic factor in just about every disease that has been looked at, especially on the heme malignancy side. And it went so far as people saying, well, maybe we shouldn't even send those patients for a transplant because they still do so poorly after transplant. Then a group from WashU made an observation that in their leukemia patients with P53 mutations, that subgroup seemed to have a very nice response to therapy with a hypomethylating agent called decitabine. And so that's an example of where something that was prognostic as a very poor prognostic factor turned out to may also be predictive for a therapy. And so I think we are coming from the angle of a lot of prognostic markers, but I think the predictive things will come, some of them with targeted therapies against specific genes, but some of them, like this decitabine story, might just come from observing our patients on other therapies.
That's a perfect segue to my last question, which is, so there have been a lot of FDA approvals of targeted therapies over the last couple of years. It seems like an acceleration. And how has that affected treatment and NGS sequencing and how those things come together in heme malignancies? Do you see the same acceleration, or do you see more clinical trials available?
Definitely. Sorry?
Go ahead.
Yeah, definitely.
Go ahead.
As mentioned, FLT3 ITD, TKD mutations. Now we have an FDA-approved drug specifically in the setting of AML that has those mutations. And but even before that was approved, we've been using FLT3 inhibitors. There are several drugs that target mutant FLT3 that we've been using off-label for quite a while. And so the fact that we were using FLT3 testing to help us with the prognosis up front turned out to be relevant for many of those patients down the line in their therapy where they may have exhausted other options, and we started to use TKIs in those patients. And there are more things coming for sure. IDH1 and IDH2 mutations are present in about 20% of patients with AML, and there are specific inhibitors being developed by multiple pharmaceutical companies to target those mutant enzymes. And that's just a few of the examples. So I think that we will see more predictive markers being used. And right now we have several clinical trials where we have to get genetics before we can enroll the patient, and they have to have certain genetics to be eligible for certain trials. And so I think this will be definitely exploding even further.
Greg or Kristen, would you like to add anything to that?
I think that Andy did a great job of covering it, so I don't have anything to add.
Yeah, I don't have anything to add either.
Okay. To close, I'd like to ask each of our panelists if they have closing remarks or in summary that you'd like to share with our audience today. Kristen?
Sure. So I think we're in an exciting time for NGS testing in the heme-related cancers. I think we're really only beginning to scratch the surface of the value that NGS testing can provide. We still have a lot to learn about the prognostic and certainly the therapeutic value of the targets we're currently testing, not to mention the new targets that have yet to be identified. So we're still very much in the discovery and learning phase regarding the clinical utility, but it's very exciting times. There's new information, it seems, that's coming out constantly, which is a challenge to keep up with. And then I don't think it's not a topic that's been mentioned yet, but then there's the whole question of can we utilize NGS for minimal residual disease monitoring? I mean, we're identifying these genetic markers in our patients. Could this be used for MRD testing? But I still think there's some technical and other challenges around how to operationalize that. But I think it's an important area, which is going to be important for our patients in the future. So with that, I'd just like to quickly acknowledge our dedicated NGS team here at MedFusion. It truly does take a team effort to have a successful NGS program, and I'm extremely grateful to work with a talented group of individuals every day here at MedFusion.
Thank you, Kristen. Greg, do you have some final comments?
Yeah. So thank you again for having me on today. So I think a lot of the things I'm going to say are just a rehash of what was said throughout. But obviously, this is I think a very exciting time for everyone involved in the field. I think next generation sequencing or even newer sequencing technologies, it really is just another tool, like flow cytometry and conventional cytogenetics that are going to hopefully help us better manage patients with hematological malignancies. And at Rutgers, we're mainly using next-generation sequencing now in the heme world for limited diagnostic and prognostic purposes, but we are starting to see it used in therapeutic decision-making in certain instances. And as Kristen said, we are exploring with our systems biologists its use in MRD detection, but that's not something we're doing clinically, at least with this panel. And I think hopefully the reimbursement for these tests, people will hopefully continue to reimburse for these panels, and a lot of that will get worked out, and insurance companies and other interested parties will make a push because I think this type of testing does have a lot of value to patients and the treating clinicians. So thank you for having me.
Thank you so much for joining us. Andy, do you have any final comments?
I think it was a great discussion. I think I just wanted to, a few of the caveats that we haven't brought up, there are still some. This isn't the panacea, like that, some patients think that if you sequence my cancer, you will have amazing outcomes and incredible therapies that would be available that wouldn't have been before. That's not always the case. Yet, I think that there is a place for sequencing in every patient. I really firmly believe that it should be done, and some of the answers that we can take from that, we won't even know how to interpret yet, but that data will be there in the drawer in their chart ready for something potentially in the future. There are some other challenges that we haven't touched on that we have to think about, like what do you do when you find variants that could be germline variants, and how would you counsel the patient and their family in that scenario? These are things that a lot of smart people are thinking about, but it seems like we probably need clinical geneticists involved and genetic counselors and have these plans in place when we start to use this in our patients. All that being said, it's really an incredibly exciting time because we have these tools that can return quantitative data rapidly that we just didn't have before, and we're certainly using this to make treatment decisions every day. So I'm really looking forward to what happens in the next 5 years.
Well, thank you so much to Dr. Lane, Dr. Riedlinger, and Dr. Champion for your contributions today for a very interesting and informative discussion. And we'd like to invite our audience to continue to submit questions, and we will address some of your questions right now. Thank you very much.
Thanks, everyone. That was a really great discussion, and I think our audience now has some tremendous insight into how NGS technologies are being utilized to improve cancer patient care. So before we start the Q&A session, I want to remind the audience that this is their final chance to submit their questions for our speakers. We've got a bunch of questions that have rolled in already, and they look really great, but hurry up and send in the rest of your questions now. We'll try to get to as many questions as we can. Simply type your question into the Q&A box on the left-hand side of your screen and hit submit. All right, since we have a bunch of really good questions already, give us a few moments on our side to get all the logistics straightened out, and we'll begin the Q&A presently. All right, everyone, so let's get to the questions. We have a couple of really great ones that have come in already. So the first question for our panel, one of our audience members would like to know, has anyone included detection of chromosomal structural changes using NGS?
So I'll start with that one. This is Kristen. So as I mentioned, we incorporate FISH for certain gene rearrangements and gene amplifications, and we also do karyotyping in most cases. But we don't currently have the capability to detect structural changes by NGS. We're doing, a DNA amplicon-based NGS method that's not well suited for that purpose. We have had, a few conversations around whether to move to that in the future, but we don't currently have any immediate plans to incorporate detection of structural changes in our NGS panels.
Okay, anyone else want to follow up on that question?
Andy,
Sure.
Just to say that it's definitely a challenge with DNA PCR-based panels, but there are some structural changes that are definitely relevant, and so there are things in development, either using tiling capture arrays that get the intronic breakpoints or RNA-based assays to look for the fusion transcripts. And some of those are available commercially, and then some in-house we have developing here as well. I think they will come, but they're definitely behind the DNA assays.
All righty, thank you, guys. Our next question, one of our audience members would like to know, what are the guidelines to follow up CHIP mutations?
This is Andy. I'll take that one. The short answer is that there aren't really any guidelines yet. You remember, CHIP really means that the patient has no abnormalities in their CBC, but has then a mutation that's detectable. We don't really find many of those patients because why would we have sequenced them in the first place? but what is more common, I think, is the patient with a cytopenia who has a mutation. We might call those ICUS patients, idiopathic cytopenia of uncertain significance. And there are no guidelines yet, but there are emerging data that, for example, if a patient has mutations in specific genes, like spliceosome gene mutations, those patients are more likely to have an underlying heme malignancy, or patients with mutations in 2 different genes, or a high variant allele frequency in a mutation that's found. And so I think that will come over time, some more clear guidelines. I think for right now, I don't think we can say anything other than you follow them clinically the same way that you would another patient with cytopenias that you didn't know their sequencing data. But I think in the back of our head, we certainly get a little bit more worried about the patients when we see that they also have a clonally detectable mutation.
All right. Anyone else? Nope. All right. Let's move on to the next question for our panel. One of our audience members asked, do you miss some of the FIT3 positive AML high size ITD, i.e. 300 base pairs by NGS detection?
I can address that question. So in my lab, we've taken a very conservative approach with regards to the FLT3 ITD detection. It is a difficult mutation to detect by NGS. So we actually run NGS for the FLT3 ITD as well as a PCR fragment-based assay to make sure we're capturing the larger insertion fragments.
And this is Greg. I can speak to our experience at Rutgers. So actually, just as we were finishing validation, I guess, of our internal pipeline for detecting the FLT3 ITD, the FDA approved a drug for FLT3 ITD positive AML patients, and that actually requires the sample to be sent to a specific laboratory where they have a companion diagnostic. So even though we have it now on our NGS panel, it is being sent somewhere else. And one thing I did notice, I think the in vivo scribe, I believe, has the patent for detection of the FLT3 ITD. And at least the commercial company, we were sending it to, states that the limit of their size detection is about 420 base pairs. So, the wild type, I think, is like 330 base pairs. And that's about what we were able to validate on our NGS panel. So I'm not 100% sure if the even the PCR gel electrophoresis really is validated to pick up larger than that 420 base pair amplicon.
All righty, thank you for that. And sort of a follow-on question to that one, which software is best in detection of the FLT3 ITD?
So I can just say, here at Rutgers, we chose to use, Amplicon Indel Hunter. I know other people use Pindel. I think, probably whatever you're able to validate, or the laboratory chooses to validate. If it works well for your lab, I guess that's kind of what people are doing.
This is Kristen. We're using the software that Illumina provided specifically for the FLT3 ITD, but we do use Pindel for CALR variant detection. We validated the Pindel for the larger 52 base pair deletion mutations that we weren't able to pick up by the normal pipeline. But since we are using an alternative method for the FLT3 ITD, we didn't look at using Pindel for that.
Alrighty, thank you guys. Next question for our panel. When reporting a highly significant prognostic marker such as FLT3, NPM1, ASXL1, CLAR that may impact therapy, for example, transplants, do you report these in Tier 1 or Tier 2?
So I'll start off with that one. I assume the person asking the question is referring to the AMSCAP guidelines that were issued on interpretation of sequence variants in cancer. Those would definitely qualify as Tier 1 variants. In my lab, we're moving to using the tiered-based system. We're not there yet. But that said, I wanted to mention that we specifically make an effort to call out the status of what we consider highly significant genes, such as FLT3 or CALR or ASXL1. So even if they're negative, we call them out as what we refer to as pertinent negatives, and they appear near the top of the report, so the status of those genes is very clear to the clinician.
And this is Greg, but we also haven't yet adopted, I think the guidelines that came out of ASCO and AMP in January, but we're also moving to that direction.
All righty, thank you guys. And our last question for our panel today: what guidelines should be followed when reporting and validation for hematological malignancies by NGS?
So I mean, there are guidelines. There is, I guess, a set of guidelines that came out from the Association of Molecular Pathology, American Society of Clinical Oncology, and CAP in January in the journal Molecular Diagnostics, which has guidelines for interpretation or reporting of sequence variants in somatic or the cancer world. And then more recently, guidelines came out again in the journal Molecular Diagnostics, I think last month, from CAP and AMP, which describe how NGS oncology panels should be validated. So I think most people are working to adopt these recommendations.
All righty, thank you guys. And with that, we've come to the end of our webinar. I'd like to remind everyone that the webinar will be archived for up to a year on our site at www.clinicalomics.com. So if you missed parts of it, you can watch it again, or feel free to forward the link to your friends and colleagues, which we always recommend. I'd like to thank Sheryl for moderating the panel, and I'd like to thank Kristen, Andy, and Greg for their informative discussions, and I'd like to thank the audience for their attention and thoughtful questions. And a very special thanks to N of 1 for sponsoring this webinar. So hopefully we'll see you again at another webinar for Clinical Omics in the near future. Goodbye for now.